Welcome, everyone. It's my great pleasure to welcome you with Operation Parent and Dr. Hatim Omar today as we discuss youth suicide on the rise. It's going to take a couple minutes for us to load everybody in the system today, so I'd like you to go on over to operationparent.org and think about registering for our upcoming webinars. Just wanted you to know, if you've just arrived, you're definitely in the right place this afternoon for Youth Suicide on the Rise with Dr. Hatim Omar and Operation Parent. For those that are brand new with us today, in just a couple of minutes, we'll take you through the technical components of the GoToWebinar system, and then we'll get started with the content today. And we have a wonderfully packed afternoon of learning together. Hi there, if you've just arrived, this is Michelle Massey with Operation Parent and Dr. Hatim Omar. We're excited to be here with you. Mary Beth Yaberti is also with us, and we are excited to have you here to learn with us this afternoon. Again, you've arrived in the right place. You're with Operation Parent, and our webinar today is on youth suicide on the rise, and our expert is Dr. Hatim Omar. So I'd like to tell you about a couple of our upcoming events. We have a rebroadcast, and the rebroadcast means that we are pulling a webinar out of our current library, and we are sharing it with you as is. So that means you will be able to listen and learn from the content. The only thing you won't have at the end is the opportunity to ask direct questions with the expert, but you'll still hear the questions that have been asked in the past, and it's a great opportunity to learn some more. The particular topic is dating abuse, what everyone needs to know. The expert is Cassie Drockelman, and she is with the Mary Byron Foundation from here in Louisville. Our next rebroadcast, we also have a live event coming up on Tuesday, December 8th, 2020, and that is talking with teens about underage drinking. That is with the national president, Helen Whitty, and she's from MADD, Mothers Against Drunk Driving. And we'd like to ask you to do something special this afternoon. If you could go on and register for that webinar with us, but also make sure that you have liked both Facebook pages, our Operation Parent Facebook page, as well as the MADD Facebook page, just to get additional details and information about that upcoming presentation. We also have a second rebroadcast planned for you, and this is from our very own Mary Beth Yaberti. It's covering 5 strategies to raise a drug-free kid. At Operation Parent, our mission is to love and support parents by providing real-world information, connection, and most importantly, hope. Before we get really going, let me just tell you a couple ways we can communicate during the presentation. If you're brand new with us, if you are on your computer screen, might look a little bit different on your phone, but on your computer screen, just click on the orange arrow and open up your control panel. About halfway down that control panel, you're going to see the question section, and we will look forward to hearing you through that question section, hearing from you through the question sections. You can submit questions privately there to us, and we will also respond back to you privately. You will be muted during the presentation, so this will be our primary means of communication. But we ask that you especially use that at any point in time that you think of a particular question for Dr. Omar. While we have his expertise here with us today, please forward those questions as soon as you think of them, and we'll look forward to getting to those at the end of our presentation. An email was sent to you earlier today containing the handouts, so you're welcome to download them from that location, or you can download them from here in the system today. So we put together, again, 5 amazing handouts for you. One is youth suicide and helpful resources. So that is a list of a bunch of resources that we put together for you from Operation Parents. The next one is titled Youth Suicide Warning Signs, and that comes from the organization Youth Suicide WarningSigns.org. 10 things that parents can do to prevent suicide. And we're thankful for healthychildren.org for that resource. And then from SAMHSA, we have a suicide assessment, 5 steps for evaluating and triaging a suicide. And we'd also like to say, due to the serious nature of today's topic, suicide, we would like to go beyond just the informational presentation that we have put together for you today. Our founder and president, Jean Shum, has offered if anyone, especially a fellow parent, might need to talk or pray, that she'd be happy to take an email and set up a time to do that. And she's at jean@operationparent.org. In our community here in Louisville alone, we know of, and there's probably unfortunately been more, but we know of 2 amazing young folks that we've lost just in the last 2 weeks to suicide. So we offer our deepest sympathies out to those family and friends of those victims. And we know that your communities are going through a similar loss. So we also want to say, if you or someone you know is thinking or talking about suicide, please tap professional and emergency resources right away. As always, we hope that you pull a lot of time, that you pull a lot of information and resources and hope from our time together. But most importantly, if you're struggling personally, please reach out for help. That's what we want to happen today. And we're so fortunate that we have an expert who's made his life calling and work the study and prevention of suicide. Dr. Omar was so gracious to agree to work with us, and most importantly, we just look forward to our time with you and learning from everything that you've learned. Thank you, Dr. Omar.
Thank you. So, hello everyone, and thank you for being with us. This is not an easy or fun topic to talk about. Unfortunately, it's a very important one that practically every one of us is involved in one way or the other. A little bit about me: I'm an adolescent medicine specialist. I started my life as a gynecologist, then a physiologist, then a pediatrician, then adolescent medicine specialist. And I became involved with suicide prevention back in, started in about 1999, when I received a call from the coroner of Fayette, Lexington County, coroner, who was an amazing guy named Dr. Dennis Penn, who was a pediatrician also. And he was just calling me to say, here, you came to Kentucky, and I'm tired of seeing young people dying from suicide. Is there something we can do about it? So we brainstormed for several months and decided that while there are so many programs around the country, none of them is working. And we realized that if we want to make a difference, we need to involve everyone, the community as a whole, parents and teachers and students and teens themselves. And that's how the Stop Youth Suicide campaign was born in October of 2000. And we are still going 22 years later. At the time, of course, I didn't really think I will be involved for 22 years. I thought I'll do a full year of massive campaign to inform the public and educate them on the subject, and then then that would be it. Leave it to others. But once we opened our website and we started getting emails from teens and parents who needed help, it became impossible to really stop. And I can tell you, since then we have probably worked with over 10,000 kids, and so far every one of them is still alive, which keeps me going. In the beginning, I think I had the same fear that everyone adult in the country or in the world has, which is, what if I try to help someone and fail, and that someone is dead? And it is a scary thought. But then I realized that, okay, what if I have 10 kids that are suicidal and I do nothing? Then we have 10 dead kids. If I do my best and I succeed only with one of them, that's still one more alive person than not. And that helped me get through and not being scared of working on suicide prevention. So that's a little history. Now we'll go to the slides and start the talk. Where are my slides now? Maribeth, can you help
Yes,
with?
sure.
I had my
You're-
slides on and then.
And then they disappeared. Okay.
Mhm.
So go up to the top and where it says PowerPoint, you've got them showing. I can see them. So it's a matter of the webcam has taken over the full view of your screen. It's working on this end. So can
Okay.
you see, can you hit your you on your keyboard, hit the arrow to advance and see if it pops in? Can you see that? It's advancing.
Which arrow?
You're advancing it. You just can't see them.
Yeah, but I can't see it.
Okay, so go to the top of your screen and where it says webcams. Do you see that?
Webcam? No, that's stop sharing. My should I click the stop sharing
Yes.
webcam?
Yes, let's stop sharing.
Okay.
And can you see them now?
Yeah.
Okay. And then
Except I'm not able to. Yeah. Okay.
okay, you got it?
I got it. All right.
Okay. All right, great.
So, so what I want to talk about today is discuss a little bit about development issues, how teens grow up from being kids to becoming adults. Talk about the epidemiology of youth suicide, how big of a problem it is, and what contributes to it, and what really can we do about it. And one of the first things that usually I like to talk about is every generation, our generation included, we always think that we are different than today's teens. That when we were teens, we were maybe better than today. And this is a prevailing concept for every generation. But when you actually try to look at real facts, this has been the same from forever. For example, here's a quote: "The son feels equal to his father, no respect for his parents anymore. He wants to be free. Students insult their teachers, and on top of this situation, in the name of liberty and equality, sex is everywhere." When you see this quote, you think somebody said it yesterday or last week, but really, this was said 3,000 years ago by Plato. Imagine that, like 3,000 years ago. When you read this, it's exactly like what most adults say today. There's another one done by Shakespeare, which he has a different way of saying things, but basically what he's saying is, maybe it will be best if we put everybody to sleep at age 10 and wake them up when they're 23 and not go through those teenage years. And of course, my favorite is Mark Twain, who says, "When I was a boy of 14, my father was so ignorant I could hardly stand the guy. But now when I am 21, I was astonished how much the old man has learned in the last 7 years." And the last one of this is again, 3,000 years ago by Aristotle. The young are permanently in a state resembling intoxication. So what I'm trying to say is essentially, since recorded history, every generation, the adults think that they were better as teens than the current teens. But the reality is teens in any generation have gone through the same developmental stages like they go today. And the difference is what society they live in. And that makes them more likely to succeed or not, depending on what we, the grown-ups, provide in terms of support. We used to think that our brains develop and complete their development by age somewhere around 17, 18, 19. But the current knowledge supported by science and brain imaging and so forth shows that really it's not complete until about age 24. And this is an important fact because if you're not complete, if your development is still not fully there, then you are more likely to make mistakes. And we the grown-ups, the politicians, everybody should be aware of this and taking that into account. Unfortunately, the only people who are taking that into account are rental car companies and insurance companies who will not rent you a car before age 25 or give you an insurance because they know that you are more likely to have a problem with your driving or something. But it is a fact. And the biggest issue is this tiny little area called prefrontal cortex, which is really like smaller than a pinhead, but this is where the decision-making center is. And until this particular area is completely developed, your decision-making will leave something to be desired, and thus you are going to more likely to make mistakes with negative outcome. And because of all this, there's a huge difference between what causes death among young people versus adults or grown-ups. If you look at adults, you see the common causes of death will be heart disease and cancer and other diseases. And among young people, for the most part, it is something that they do. It's accidents, suicides, homicides, other unintentional injuries, and other things like eating disorders and pregnancies and sexually transmitted diseases and overdoses on drug. Roughly 90–95% of death rate in young people under 25 is on paper preventable. And while we all understand that we can't prevent 100% of it, there is no reason that we cannot make a dent of it, that we cannot prevent some of it. And so this brings us to youth suicide. Youth suicide is traditionally, throughout the last 30 or 40 years, most what you heard, and when I was in medical school, I was taught, oh, suicide is a mental health problem. 95% of suicides happen at the peak of a depressive episode, and so forth. And my experience in the last 20 years have taught me that it is actually in young people a lot less common to be related to a mental health problem than not. And it is more likely to be a public health problem than a mental health problem. And I've been fighting for the last 20 years to change that narrative wherever I can. And like any public health problem, if you want to deal with it correctly, you have to define that problem, identify the risk factors that cause the problem, then develop interventions and evaluate them if they are effective or not. And if you evaluate that they're effective, then you implement those interventions in various communities and see how effective they are. Because the bottom line is, as long as we misdiagnose something, if we keep focusing only on the mental health aspect of youth suicide, we will miss the majority of youth suicides, and we will continue to run through the problems that we are running into today, which I will illustrate now. Very few people think how devastating suicide is, but if you look at this slide, and you can see that even though this is from 2001, the latest data essentially stays the same. Suicide kills worldwide more than all wars and all homicides combined. And that's very few people actually know this or think about it, because when we hear about a war and crimes and things, and we don't realize that suicide is a lot bigger problem across the globe, and it's responsible for more death than anything else in that regard. If you really want to look at the numbers, and they're changing every year. When I put this slide together just a few months ago, the data was 13 minutes, every 13 minutes in this country, somebody dies from suicide. As of last month, this number is now 11 minutes, every 11 minutes, not every 13 minutes. On an average day, about 127 people to 140 people will die from suicide, and about 2,000 will attempt suicide every single day. Suicide in 2016 took 45,000 Americans. Last year we had 48,000 Americans. Just think about this for a second. If we have a passenger jet with 130 people on it crashing every single day, we would be doing something about it. Yet this is happening every single day for a very long time, and we still are not doing enough about it. So roughly we are looking at 850 to 1 million people dying every year from suicide. And a lot of those suicides, between 30 and 50% of them, happen to people who are receiving psychiatric care. So if it was just a mental health problem, we would probably be making a better dent in this. A few other facts is that there are some groups of youth and young adults who are at much higher risk than others. Unfortunately, in this country and across the globe, military personnel are at much higher risk. We are looking at 40, 45 per 100,000 in our military, which is a record number of military suicides. Rural populations, LGBTQ youth, very high percentage of Native American and Alaskan natives and kids with chronic illness. We know that college students, especially the first year in college, almost 1 in 3 is feeling depressed and unhappy. We are spending over $80 billion in treatment for depression. And if we were to put 1 billion in prevention instead of treatment, we would be a lot more effective than doing that. And for the young people, I think it is more important for everybody to understand that we lose more teenagers and young adults to suicide than everything else, than cancer, heart disease, AIDS, birth defects, stroke, pneumonia, influenza, chronic lung disease combined. As an example, on average in Kentucky, we lose between 46 and 50 kids to suicide every year, and we lose somewhere between 5 and 7 to all those diseases combined. Yet we spend somewhere around $700 on those diseases for every penny we spend on suicide, which makes no sense. And I mean, if something is killing so many people, you should be paying more attention to it and investing more resources in it. Another fact is that traditionally and historically, attempted suicides among girls are about 3 times more than boys. They are more likely to have compulsive decisions, and that we see more. But completed suicide is the opposite. Completed suicides boys complete suicide about 4 times more often than girls, and the main reason is the choice of means. What do they use to kill themselves? Boys generally use firearms, which are a lot more lethal, and girls usually would use things like medicines or superficial cutting or something like that. Recently, there is a significant increase in suffocation attempt. The disturbing part, though, is over the last 5 years, we are seeing a huge increase in the percentage of girls who are using lethal means like guns. And that might explain the sharp rise in completed suicide in the last few years, and it will, if this trend continues, it will be even more and more as we go along, as long as they are using more lethal means. If they're attempting 3 times more than boys, and now they are using the same lethal means, then we will see a continued sharp increase in completed suicide. If you look at the data in the last 40 years, you'll see that youth suicide have even more than tripled in the last 4 years. So this epidemic of youth suicide continues to get worse and worse, not better or not controlled. If you know anything about the Center for Disease Control Youth Risk Behavior Survey that's conducted every 2 years, every 2 years we see an increase in the number of kids who report feeling sad or unhappy, somewhere around 30% in 2017. And that's a huge number. 1 in 3, that's your kid and my kid and everybody's kid is at risk. And this is the very latest data that we just got back from the CDC in 2019. And as you can see in the slide, those are the number of kids who are actually attempted suicide. And it is the most disturbing that I ever seen since I started working on suicide. First, because on average, as you can see, that even among the lowest risk group, the Asian kids, we're looking at 8% attempt. If you look at Native American and Alaskan Native, we're looking at over 25%. That's 1 in 4 kids are trying or attempting suicide. Traditionally, until 2-3 years ago, African American kids used to have a lot lower number than white and Hispanic kids. This is the first time we see a sharp increase among African American kids. So all those numbers add up to show that we will have more and more attempted suicides unless we start doing something good. So what happens to these kids? Why do they reach a point to choose to stop their life? Essentially, I am relying a lot on what I hear from the kids themselves, because I think that's the most important factor that we need to understand. What do they think? And what you will hear if you talk to kids who feel suicidal is, I'm in pain that I can't stop. And because of that, I can't think clearly. I cannot make decisions. I cannot see any way out. I can't sleep. I can't go to work. I can't get out of the funk that I'm feeling. I'm sad and I can't get any less sad. And I don't see a possibility of change. I don't think I'm worth living. I can't get anybody's attention to help me, and I can't get control of my life. Remember, because teenagers don't have completed brain development, which means that their abstract thinking is not there. So they are more concrete. And what that's in the simplest possible way to explain is, a concrete thinker, if something goes wrong, they don't see tomorrow. They cannot think that, okay, I have a problem, but I will work on it and it will get resolved. Abstract thinkers think that way. Concrete thinkers think, okay, I'm in trouble and that's never going to get better. So my life is over. And that's why it's more likely to have, an immediate compulsive action. I get letters and emails and from a lot of kids all the time, every single week. And these are just some examples. We don't need to read all of them, but essentially they come to the same thing. Like in this here, I feel I fail at everything. I only feel sad and angry. I try to read, I try to do other things, but I still can't do it, and I don't see how it's going to get any better. This is another one that's same story. I stopped being happy. I can't find anything that helped me out. I feel lost, hopeless, worthless. And this is the type of thing that the kids go through. before they try to commit suicide. In this slide, I just put a few pieces of information to show that this is a worldwide phenomenon, and it's starting to get to younger people, even younger than traditionally, like the 10 to 14 age group, and like the Aboriginal child suicide crisis in Australia that happened 2 years ago. Here last year in Lexington, we had 5 suicides of kids under 14 in a very short amount of time. Stories about suicide due to bullying in various countries and places. A lot of increase in suicide rates among medical students and medical residents. Almost half of transgender kids have reported either feeling suicidal or attempting suicide. And one of the things that really pushes against the notion of mental health causes is what we call same-day crisis or same-day suicide. For example, here's this kid who's a 16-year-old boy who had been suspended from school for misbehavior. He went home. His mother didn't even bother to ask him what happened. She just grounded him, and they got into a loud argument. He ran from his room, went to the basement, found his father's gun, and shot himself. He has never had a mental health problem, doesn't meet the criteria for any depression or anxiety or anything else. It's just the typical 16-year-old when, okay, so the school suspended him, mom grounded him, he has no life. And at the same time, he had access to Amin, and he is dead. If this kid received a little bit support when he got home and his mom treated him differently or listened to him, he probably would still be alive. Here's another example. 17-year-old who's been bullied in school, and some of the bullies told him, why don't you go home and shoot yourself? Nobody will miss you. He doesn't have any mental health problem, never thought about suicide before, but he went home, found his dad's gun, and killed himself. Same story. It's a same-day suicide. And if you look at the data among young people, people under age 30, roughly 25% of all suicides are same-day suicide. And this number continues to be very high, up to around age 40. So these kids don't have a mental health problem. They're not at the height of a depressive episode or anything. These are kids that go through an incident, something, a tipping point, and they don't see tomorrow. And if nobody had prepared them ahead of time, and if they have access to Amin, then that's what you're going to see. You probably heard, some of you at least, about the incident where this young lady encouraged her boyfriend to commit suicide, and he kept trying to back out of it, and she kept pushing him until he did commit suicide. And this is now new with the electronic media and the cell phones and all those, that these didn't exist before, and now they are. So she practically killed the guy, not with her hands, but by continuing to push. And after 2 years of legal issues, she was sentenced to 18 months with time served. So practically she got away with nothing. Every day or every month, something new comes up on the electronic media. You may or may have not heard about something called Blue Whale, which is an online game challenge where kids challenge themselves to take 50 obstacles. That includes everything from self-mutilation to horror films and so forth, including suicide. And this was one of those stories on this slide, the story of this young person. The saddest part for me is what is happening to our very young, the 10 to 14 age group. Until 6-7 years ago, suicide in this age group was number 4 or 5 on main causes of death. Since 2016, it's number 1. And that's what you heard Michelle in the beginning, just one of those kids in Louisville just last week happening. And we are seeing a lot more of this age group committing suicide than ever before. So overall, this is a big public health problem that's affecting all of us. And one of the issues that I wanted to bring up to show where mental health stands in this. So if I'm evaluating a young person for suicide and I want to look into, is there an imminent risk of suicide? Then here's what some of the data that you can look. If a kid was hospitalized in a psychiatric hospital and discharged from there last week, their odds of suicide have just increased 278-fold. If they were discharged last month, then their odds of suicides now are 133 times more than it was before their admission. Even if they were admitted last year to a mental health hospital, their risk is still about 34 to 61. So, putting a kid in a mental health hospital doesn't mean we're curing them. And part of that doesn't say, it's not, how should I put it? It does not mean that mental health care is not good. It just means that whatever caused that kid to be admitted to a mental health hospital did not resolve with the admission to the hospital. And for the kid who is a concrete thinker, that added to the feeling that it's hopeless. That, okay, I tried help and gone, and it didn't help me. Part of it is because of our healthcare system, where most insurances will not pay a long time. So you admit a kid to the hospital and keep them whatever the insurance pay for, and then you discharge them. I can share with you, I had a patient 2 years ago that was discharged from a mental health hospital after her second attempted suicide on a Friday afternoon with her parents out of the country. And she was dead Saturday before noon, less than 24 hours after discharge. Those things continue to happen. Kids who have attempted suicide in the past have about 22, 23-fold increased risk of suicide. Kids who are using drugs, illegal substances, are at a 7-fold increase. And if everything being equal, if your kid and your neighbor kids, everything is being equal, but one of the households has a gun and the other one doesn't, just having the gun at home is going to increase your kid's risk of suicide 5-fold. And those are important things for us to understand if we want to do anything. From the mental health diagnoses that actually proven to contribute to suicide, the most common is bipolar disorders, where you see about 25 to 50% suicide attempts and anywhere between 10 to 20% actual suicide. Kids who have schizophrenia will have somewhere 20 to 40% risk of attempting suicide and about 9 to 13% actual completion. But if you look at major depressive disorders, only 2% of those who are treated outpatient setting will commit suicide compared to the bipolar or the schizophrenia. And about 4% of those who are treated inpatient. With a lifetime history, it will be like 7% of the men and 1% of the women. So us keeping just blaming mental health on this is making us misdiagnosing things and missing all the suicides that are not related to mental health. And after all this and long fight across the globe between a lot of the people who work on suicide, finally, both the World Health Organization and the Center for Disease Control now on their website will show, like the CDC has a big banner there that says 54% of all suicides have nothing to do with mental health. And that's really important for us to understand. It's more a complex, multifaceted thing, not just strict mental health problem. And once we get it right, then we are more likely to get the treatment right. If we diagnose a disease wrong, then our treatment for it will be wrong and not successful. I wanted to put a few things about self-harm, because a lot of time people confuse self-harm with suicide attempt. In my experience, and also based on the data and the science, self-harm is more like I'm struggling, I am in mental anguish and pain, and use self-harm as a coping mechanism. Most of the kids that I have treated with self-harm did not have any suicidal intent. Now, some of them are, and they will be at higher risk for suicide, mainly because whatever is causing them to do self-harm is also can lead to that. But the self-harm itself is more likely to be a coping mechanism rather than a suicidal ideation or attempt. Physiologically speaking, when you cause physical harm, like cut yourself or cause physical pain, then your brain will release a chemical called endorphin, which is really similar to morphine. So the more you cause self-harm, the more endorphin will be released, which makes you feel better. So then you become addicted to it, just like you become addicted to any type of opioid, and you will start cutting more frequently or more deeply, or causing more harm to that. Because again, those kids, what they tell me is my body looks how I feel. I do this because this is how I feel deep down. Risk factors for it is generally kids who are college age, a lot more frequently in female gender, kids who are substance abusers, those who have personality disorders, conduct issue. In my own experience, the most common kids that I see is kids who have eating disorders and kids who have a history of either family violence or alcohol abuse, or have been victims of sexual or physical abuse as young kids. So why do they do it? Again, they do it to express their emotional turmoil. They actually try to do it to stop suicidal ideations or attempt, but again, it becomes an addiction. And the urge to self-harm becomes more and more frequent, especially in eating disorder patients who feel like this is a way to punish themselves. The thing with it is it escalates. Like, here's one of my patients who for the first 4 years was doing this, very superficial cuts. But with time, she started needing to do more, and she moved to a lot more deeper cuts, more painful cuts, where the need for that endorphin release becomes more and more, which we were talking about in terms of addiction to it. There are several types of self-mutilation. One of the most common types called stereotypical, and we see that mostly in institutionalized patients, either in juvenile detention or in mental health hospitals, where the kids keep doing the same thing over and over, banging the head, biting their fingers, something like that. Then you have the superficial or moderate type, which you see all the time, and the most common type of them all. It's repetitive. It can be carving or burning or punching or scratching or self-cutting. And most of this happens in teens. Next one is very graphic. So if anybody doesn't want to see a graphic picture, don't look. So this is what we call major type. And those pictures are not the worst that I have seen. I've seen things including cutting body parts, to similar to here, where you see the toes are cut, damaging their eyes, all kinds of things. I've seen a kid who castrated himself. So this is a very, very major. And again, these are kids who still don't want to die. It's just they want some kind of physical pain to relieve their mental anguish. So now we know there is a problem. We know it's a big problem. and it's affecting everyone. So what can we do about it? You will see million forms of, everybody tells you all kinds of things. Here's how we do it, you know, from QPR, Columbia Screen, to all kinds of programs around that talk about suicide prevention. And everybody claims that their method works. I am sorry to say that until I see somebody shows me actual data that this or that program has led to decreased suicide in this society or that society or whatever locale, then I don't take any of this as, I mean, they claim to be evidence-based. But evidence-based means what? In these cases, what you're going to see is evidence-based on the people who attended that and thought that this is very effective. But none of them had showed actually a dent in suicide attempts or suicide completions in the area if they are implemented. So based on everything that we talked about, suicide seems to be a very complex problem. In youth, in part, a lot of it is spontaneous, quick, because of lack of complete development. So if you look at throughout history and throughout any studies that you look at, for a kid to do well and not to be at risk for suicide or homicide or drug use or pregnancy or anything else, you will find that throughout history, any teens who have a caring adult or a group of adults that he can actually talk to or they can listen to him, if they have a safe place to interact with that adult, and very importantly, if you give them something useful to do, then they are less likely, again, to be a victim of suicide or drug use or pregnancy or anything. One of the best studies ever done, and it's still ongoing, it's called the Adolescent Health Study. And you can look it up, it's public data, it's under Adolescent Health Study. It was started in 1984 with the cooperation of University of Minnesota, World Health Organization, CDC, and Johns Hopkins, and many other entities. And basically what they did is that they recruited 157,000 sixth graders, and they screened them. They just interviewed them. No intervention, just following them every year. And they will continue to follow them until they're dead, basically. And this was done in 5 different continents, 37 different countries. And if you look at the data, you're going to see the same thing, is kids who had caring adult, a safe place to interact with that adult, and something useful to do, are at lower risk of all negative things like suicide, like drug use, like early teen pregnancy, like sexually transmitted diseases. And kids who didn't have that support system are more likely to have it. And that's one of those things that we need to understand. It's not about poor or rich or socioeconomic status or whatever. It's about, do you have a support system or you don't? And that's why until, like I said, in the US, until 2-3 years ago, for example, Black kids tended to have a lot lower suicide rate because despite the bad economic situation, they had better support system. If not the family, then the whole neighborhood. Same thing in say Middle Eastern countries where I grew up. I mean, we didn't even hear about suicide because if I didn't have a parent, I had the whole village was my parents. Everybody else in the community helped each other. Same was in the US in the past, 50, 60 years ago. The problem now is most of our kids don't feel like they have a support system. They're even scared to go talk to their parents. A lot of the kids who talk to me will say the same. I can't really talk to my parents. They won't listen. So for us to make a dent, for us to make a difference, we should start from the bottom up, not from the top down. And that means who is around our kids, around our youth? It's their peers, it's their parents, it's their teachers and school personnel, and then society as a whole. So we should start with the kids themselves. when I started working on youth suicide prevention, that's one of the first things I wanted to do, is work with the kids, how to protect other kids, how to protect their peers. And one of the survivors of suicide attempt came up with the motto of, hey, I'd rather have a mad friend than a dead friend, which basically she was teaching the other kids that, hey, if you see something, if you see one of your peers struggling, offer help, or if it's not accepted, talk to somebody else to provide that help. Then we move on to parents. Having parents who with good relationships with them is a huge protective factor. Sadly, in some of our areas, a lot of our kids in some of the rural areas where I worked in here, 80–90% of the kids didn't have two parents, or if they did, they could not communicate with those parents. And part of it is, of course, because parents also need support and need help, need understanding. So we need to do a lot of things to help the parents how to communicate with their kids, most importantly, how to listen to their kids. We can work with teachers and school personnel. And I'm proud that Kentucky was the first state to mandate suicide prevention training. After a lot of work and advocacy, that bill was passed a few years back and signed into law, and now all school people are supposed to get some training about youth suicide prevention. So if we start with this, get the youth, the parents, the educators to work together, we are more likely to provide that support system. And if that support system exists, then it is more likely for them to succeed. Because if we continue to tell kids, well, if you feel bad, call the suicide hotline or whatever, I'm not sure that's going to help. Like one of my patients said, I called this suicide prevention hotline, and the feeling I had is that there is this lady there who's doing her nails and can't wait to get rid of me on the phone. That is not going to help. And if you talk to any teenager who called the hotlines, that's the response you're going to see. They're not going to do it again. It's not the fault of the people there on hotlines. It's the fault of people who did not train them well enough how to talk to teenagers, how to listen to teenagers, how to take everything that the teen says very seriously. So we can do it. We have to increase awareness, dispel the myths, help educate everybody, and learn what the warning signs are, what elevated risk factors are. We need to do things like this, a lot of seminars, works with the news media, work with church-sponsored programs, civic organizations, anybody, because this is affecting every single one of our families and our households. There are still myths out there, like, oh, if you talk to someone about suicide, you will give them the idea for suicide. Or someone who talks about suicide is not really at risk. Or suicide is impulsive and there is nothing you can do about it. Those myths, unfortunately, are dragging us backward and making it less effective. So if things that we should all learn how to observe is any sign of concern, like suicide threats or previous attempts, a kid that's becoming depressed, a kid who is acting out of character or making final arrangements, things like threats like I would be better off dead, or you won't have me around much longer, or I wish I was dead, or, I'm going to kill myself. So any example of threats like that, we should take very seriously. I've had dealt with a lot of parents who say, oh, she doesn't mean it, or he doesn't mean it. No, they mean it. We always have to take it seriously. They're trying to get attention. They're trying to get help. And yes, maybe the first time they attempt, they are just trying to get more attention, which is fine. That's the whole point, is if they want attention, or we need to provide that support. They want attention because they need support. If they have attempted suicide in the past, like I said, about 22-fold increase in their future. So even so-called half-hearted attempts, we should take very seriously, because there are calls for help And if the kid doesn't get that help, then next time it's going to be very serious. So if your kid have attempted suicide or indicated desire to attempt suicide, engage other people who are in touch with this kid, like school officials or counselors or parents. If your kid is doing things that are not typical for him or her, and that can be anything, you know, sleeping too much, sleeping too little, eating too much, eating too little, used to spend 15 minutes doing makeup, now doesn't do that at all, used to be interested in shopping and getting new clothes, now it's not, used to be a straight A student, now is getting worse, used to have friends and now it doesn't. Any type of abrupt change should be a red flag for us. If the kid is making final arrangements like giving away positions and driver's licenses and collections, or visiting friends and saying goodbyes, or sharing funeral plans, any of those things are red flags, and we should be prepared, all of us. It will not improve ever if we rely only on healthcare provider, being just regular doctors or mental health provider. This is going to need every adult who has interaction with kids. So if you notice something or hear something from a kid, build a neutral but empathic relationship with this kid. Talk about suicide openly, agree with their suffering, and first listen to them, then try to work with them on finding a solution. Ask if there is something new that's tipping them off. Have in mind that about 80% of kids who are about to attempt suicide will communicate their intent or will try to get some help. It's different between boys and girls. Girls generally will internalize, you know, start ignoring themselves or feeling depressed. Boys are more likely to misbehave when they feel bad. But either of them might start saying things like hopeless statements that no point is going on, I can't take it anymore, I have nothing to live for. And this is where you can if any of those kids say, and you don't have to be a professional to do this, you can say just something like, I'm glad you told me, I want to help, I'm going to find someone else to help also, but most importantly, I'll stay with you or stick with you or talk to you or listen to you until things passes. The worst part is to say something like, oh, it's just a phase, it's gonna pass. These kids don't get it. We said about that concrete thinking. They don't see tomorrow. So don't tell them that, or you'll snap out of it, or stop being so selfish, or you're just trying to get attention. And most importantly, the favorite sentence of most adults, get over it. That basically you are tell the kids, go kill yourself. It's not important to me. And that's what we need to avoid. But a lot of things like, don't let them bargain you out of getting them help. The question of no suicide contracts, I can't speak for others, but I never use those. And the reason is because if the kid is to trust me, they want me to trust them. And I heard it from many of those kids say, if you want me to sign the piece of paper, that means you don't trust me. How do I trust you? So I generally either shake hands or give them a hug, or talk in person, and just like two people who trust each other. I found that a lot more effective than having sign a piece of paper. Very important not to threaten them or make coercive statement. Hey, if you don't promise not to do that, I'm going to send you to the hospital, and things like that. I try to keep them out of the hospital, not put them in the hospital, because you saw the data, what happens when they go to the hospital. One very important part is that teenagers actually, even those who are at the point of killing themselves, they still care about others. They're very caring. They care about their parents, they care about their peers. So it's really important to emphasize to them that suicide is not going to take the pain away from you. It's just going to put it on somebody else. You know, what's going to happen with your surviving parents or surviving classmates or peers or friends? That is very effective for these teens. They don't want to hurt anyone. They think that they're a burden, and if they kill themselves, it will be easier for their family. So we need to make sure that they understand that. People who work with teens, and I say providers, but really I mean anyone who works with teens, being a teacher, a doctor, a nurse, a counselor, a parent, a neighbor even. If you feel that something is not right with a kid, ask them specifically, what are you doing for fun? You know, the average kids will always tell you what they do for fun. If they can't answer that question, that's a red flag. Tell them ask them to say something good about themselves. Same story. If they can't say anything good about themselves, that means they feel that they're not good enough. What do they want to do when they grow up? Even though that changes every day, but they always have a goal, unless they feel that they're not going to be alive. And that's another red flag. You can ask very specifically, hey, tell me about your last week, if you want to divide it between happy and unhappy time. And you'll be surprised. I mean, I never forget a kid who told me I was unhappy 5 days and 18 hours last week. These kids suffer tremendously, and it is important for us to be upfront with them. We need not just the parents and the teachers and the peers. We need also professional organizations like Society for Adolescent Medicine, American Academy of Pediatrics, and others who are supposed to be in the forefront of helping teens. I don't think any of them is doing enough. But all of us, at least until other factors, all of us, parents, teachers, neighbors, anyone, can be a lifesaver. Ask questions, respond to the emotions, encourage those kids to do something. And I'll just give you a few examples of, you know, what happened. I mentioned the Stop Your Suicide campaign. We started in October 2000. And Kentucky always was higher than the national average in all aspects of things like considering attempting suicide, making plans for suicide, attempting suicide, completing suicide. By 2013, actually, for the first time in our history, Kentucky was better than the national average. And it was mainly because of the areas that we worked very thoroughly in. Here's an example of Lincoln County, for example, where we started a school-based programs there in 2008 until 3 years ago, where we, in the beginning of the year, we tried to interview or meet with all the kids, screen them for risk factors for anything. And then if they are doing well, we tell them, hey, you're doing great, but if something changes, we are here. Come talk to us, it's confidential, we'll help you. About everything, and we provided that intervention right there in the school. And you can see the difference over a 5-year period since we started that program from 2000 to 2007. Kentucky essentially stayed the same or slightly worse, while you know, Lincoln County was a lot better. And this number actually would have been even better if we had access to the kids 18 to 24, because we had access only to the kids until age 18 in the school, and we missed out on the older kids. But it is doable. You know, another example of this, I work on suicide prevention across the globe, and one of the areas that has very high youth suicide rate is New Zealand. And they asked me through the Fulbright Scholar Program to help out there. And back in 2009, one of the areas that we wanted to focus on was an area called South Waikato, which is mostly Maori population, native people. And this community that's less than 90,000 population was averaging 6 suicides per month, youth suicide per month. And basically after training the community, the parents, the teachers, the tribal leaders, everybody else, we bought 4 cell phones and ensured that there is 4 volunteers at any given time carrying those phones, and explain to the kids that any kid who needed help can call one of these phones. None of these volunteers were a professional. they're just caring adults. And within a year, that rate dropped from 6 per month to about 6, 7 per year. And it's still sustainable today. So it can be done. We need to also modify the media role. The media have to stick to facts to educate the public, focus on the suffering of survivors, not the traditional way where when a kid dies from suicide, you see the obituaries where he was a great kid, he was this and this and that, like glorifying him, which then encouraged other kids to do it too. Hey, maybe they'll talk about me like that. But if we focus on this kid died from suicide, here's what his parents are going through, or his siblings, or his classmates, that work better. And we need to, again, keep reminding people that suicide is preventable, and those myths are not useful. I wanted to add a few things about what's happening since we started the pandemic. Since the pandemic started, we are seeing depressive symptoms rising across the the board. There is increased incidence of depression, especially among population that already were at high risk. Like kids whose parents lost their job, or kids who are LGBT, or Native American or African American kids in poor places. Those rates are increasing. Among 18 to 24-year-olds, as of late June, about 25-26% reported self-harm or contemplating self-harm. And about 62% reported anxiety or depression. That's a massive increase compared to prior to the COVID-19. But this is affecting also a lot of adults in the US. 31% of adults are reporting anxiety or depressive symptoms, increased substance abuse, considering suicide, stress-related problems are all on the increase. Most US residents, anywhere between close to 52% or higher, had symptoms of mild depression or greater. Before COVID, that number was 25% or less. And this is across the board, mild depression, moderate, severe, all of them are increasing. One misinformation, sadly, that was being distributed by some of our politicians and people is that, oh, this doesn't affect young people. This is just data showing in every state in the country, the percentage of younger kids contracting the virus is increasing. Not a single one is decreasing. And this is going to continue to get worse, not better, until we find a solution for the COVID. So we have to pay attention to that. This is just a response from 128 teenagers that I asked, just send me one word, how they feel during COVID. And as you can see, there's anger, frustration, confusion are the top feelings that these kids have. Some are feeling fearful, some sad, some boredom, but a lot of bad feelings. So the bottom line is suicide is a big public health problem. We can make a dent in it. We need to stop thinking about our teens as a problem to be solved and think of them as a resource to be developed and help them out. I wanted to quote a Chinese proverb that I really love. It says, superior doctor is one who prevents illness. Mediocre doctor is one who attends to an impending sickness. An inferior doctor is one who just treats actual illness. But the most important thing I want to leave you with is a quote from our 32nd president who said, we cannot build the future for our youth, but we can build our youth for the future. Thank you.
Okay, thank you, Dr. Ormer. That was phenomenal. Let me just get my screen back to where we need it to be, and hold on just for a second, everybody, and we will be all set to go. There has been a lot of questions that have come in, and so as we get going, I have been flagging them. So if you posed a question during the presentation, just know we did see them. We are going to be flagging them at different times just so we can go through them. Just in the meantime, while you consider if you want to add another question, again, these are the upcoming webinars. You can find all the webinars at operationparent.org, and you want to go to resources. And we have in there the link for webinars. You click there, and then you can register for any of the ones that are available. So feel free to do that. These are also an option, our parent handbooks. We are finally getting ready to launch our 8th edition of our parent handbook. So there is a Black Friday special that we're offering for the new 8th edition parent handbook, and that is for the middle and high school book. It will come out officially on November 25th, but you can pre-order it using the discount code there that's listed, and that'll allow you to get 20% off of the purchase of one. Again, this is the newest version of our parent handbook. A lot of people have been asking about when we are going to get the new version out. We also have a special on the 7th edition of the middle and high school handbooks, where you can take 50% off the purchase of one parent handbook. So the codes are here. Also, you will, in our follow-up email that you receive tomorrow afternoon around 3:30 in the afternoon Eastern time, these codes will be in that follow-up email along with the webinar recording link, survey link, and certificate of attendance for those who attend the live event. That is in the follow-up email that will be coming out tomorrow afternoon. You can follow Operation Parent on Facebook, Instagram, and Twitter. And with that, Dr. Omar, I'm going to start going through questions. And please, everyone, just understand, we are going to go to 3:30, maybe just a little bit over, but any questions that we do not get to will be sent to Dr. Omar, and then he will answer, and we will get those answers out to you via email. So your questions will be answered. So the first question is, Dr. Omar, should I tell the parents of a youth I know whom I think might be thinking about suicide? The youth has begged me not to tell her parents and that she is struggling emotionally.
The first thing I think of is what kind of parents are they? Because generally the answer would be yes, we need to involve the parents because they are the ones at home, and we need to explain to them that there is a risk here and they need to pay attention. However, if the kid is suffering because the parents are a cause of the suffering, like if there is abuse at home or something, then that becomes a different ballgame. But generally, the answer should be yes. We can tell the kid, listen, I'm going to talk to your parents, but not telling them that you are going to kill yourself now. I just need them to be more supportive and give her time. She might not agree the first day, but might agree the second day or the third day. But if it's not an abusive situation, I would, because the parents are still there and they might not know what to do, but at least they would be observing things.
Okay. So if they can't go to the parents, who should they go to? Who, if they are very aware that maybe there's something going on in the house. So where could they go?
So I have had 3 or 4 instances like this where I'm working with the kid. The condition at home are not good enough, and essentially it's an abusive condition, not bad enough to take the kid away from home, but it's not going to be supportive. So the way I work with these kids is I'm their support system. I explain to them that I'm available anytime. They have my cell phone, they have my email, they have whenever they feel bad, whenever they want to talk. I also try to find other resource, if they have another doctor in local community, that's if they are far away from me, if they have a teacher, a school counselor, anybody who they else. So, you do your part and get more help and keep encouraging the kids to involve the parents. At some point, once we reassure them that we will work with the parents, generally they would agree.
Okay. All right. Thank you. Let's see. Somebody was asking about their daughter has been struggling to find the right medication and dosage to help her feel better. We've been at this for over a year and have tried 3 different medications. The one she listed was Zoloft, Prozac, and Cymbalta. We're scheduled to talk with her therapist and psychiatrist in a couple of weeks, but we are getting frustrated. Any advice?
Yeah, it's part of the problem with antidepressants is there is no one size fits all. So the way I work is figure out what the problem is. Is it is it bad depression? Is it anxiety? Is it a combination of both? Is it bipolar? Pick a medicine based on that. And the most common error I find is it's not the wrong medicine, it's the wrong dose. Like for example, one of the common errors in medicine is the thinking is if you are small, you need a smaller dose. If you are big, you need a bigger dose. Well, with antidepressants, that's not actually true. The group of serotonin reuptake inhibitors like Zoloft and those medicines to get to the brain need enough fat molecules to help them. So if I have say an anorexic kid or kids whose BMI is very small, very thin kid, they need a lot higher dose than a kid who is normal weight. And a lot of time what I see is exactly the opposite. A kid whose BMI is 17 and they put her on 10 milligrams of say Prozac or something, and that's extremely low dose. None of it is good to the brain. So I can't, of course, get advice without knowing the patient, but whoever is prescribing those medicine should be looking at all those aspects. And if sometimes one medicine doesn't work, another would work, or a combination of medicines can work. But it takes experience. It took me 20 years to start, getting things
Yeah.
right more often than not. So they need to discuss more thoroughly with whoever is prescribing. But there is a medicine for everyone. The question is find the correct medicine, find the correct dose.
Okay. Somebody's saying, has suicide increased amongst classes and ethnicities?
Typically, until I showed a few slides about that, until like 4 or 5 years ago, the highest suicide rate in the US was among Native American and Alaskan kids, then white kids, and more likely to be white upper middle class kids rather than poor kids. Black kids used to have very low suicide risk. What we are seeing is continued increase risk among Native American and Native Alaskan kids, sharp increase among African American kids, some increase among Hispanics, and continued increase among white kids. Really, it's across the board increase. It's just disproportionate. We still have the lowest rate is among Asian kids. Of course, also depends on other factors, not just ethnicity. If you're white or black or any ethnicity, but you are transgender or lesbian or gay, then your risk is a lot higher. If you are in the army, in the armed forces, the military, then your risk is higher. So it's more complicated than just the ethnicity.
Okay. Somebody's writing here, the 15-year-old daughter has had multiple attempts unknown to parents. So this must be a step parent. She doesn't see the seriousness of what's going on, exhibiting laughter and joking about it with no filter. Knows that she needs help and was just an inpatient, which helped a little. Perhaps people are no help due to lack of participation, and kids know each other. I'm afraid for her, and I don't think she'll get enough help, especially to get into a better place. She is idealizing in particular her depression. She's generally a good kid who is hurting more than she deserves.
I'm scared for her too. This is a very high risk patient. First, because of multiple attempts, and second, because of the inpatient admission. So she the biggest problem with inpatient is not securing outpatient follow-up. This is a kid who needs frequent follow-up by both a medical provider to adjust medications as needed, and by a counselor who is good enough to do that. I know it's very hard to find good, experienced people in both, but you have to keep looking. But don't leave her without help. This kid, if she doesn't get good help, we might lose her. We don't want to get to that point. So
Right.
push very hard, involve everyone. If you can find a friend, one of her friends, one of her peers, that might end up being more helpful than a doctor. Same thing if you can find a teacher, a school nurse, a school counselor, somebody in the school system. And of course at home, she needs to be shown, we love you, we care about you, we don't want, and this has to be repeated every 10 minutes if I were them.
Okay, that's great. Thank you. Says you might, as somebody was just saying, you might end up talking about this, but why do you think there is so little money and resources spent on preventing suicide?
Like Mitch McConnell once said, it's not a sexy topic. Unfortunately, our politicians will finance things that are that get them votes. So of course they're going to put more money in cancer because it sounds really great. Here we are helping kids with cancer. Never mind that cancer kills less than 3 kids in Kentucky, but suicide kills more than 45, 50. And that's really the biggest. It's an uncomfortable topic. I mean, one of our legislators, I work a lot with them, told me I can't go to the communities and run based on suicide prevention. I'll talk about diabetes and asthma and cancer, but I don't want to talk about preventing teen pregnancy and STDs and suicide.
Wow.
And that's really the biggest problem we're facing.
Yes, I would imagine. Um, how much of the increase do you believe is linked to widespread use of social media?
I mean, nobody can really quantify it exactly. There are no good studies, so it's more. I can give you some data showing, for example, that electronic media had added significantly to cyberbullying. Cyberbullying also adds to increased suicide attempts. Social media and electronic media had significantly altered sleep patterns in kids. And if teenagers are not getting 8.5, 9 hours of night sleep, they're more likely to develop more anxiety, more depression, and to increase suicide. So does it have an effect? Definitely. But it also can have a protective effect if you are with the right people. So far, I think there is more negative, so more contribution to increase suicide rather than decrease suicide, like I showed based on those games and challenges and effects. So the bottom line is, I think everyone who is listening and who is a parent or knows a parent, the best advice I can give everyone is start talking to your kids when they are 6 or 7 or 8. That's when they still are likely to listen to you. And the message I would give, like I gave my own son at that age, is I love you, I care about you, I know you will make mistakes, but I promise you, if you tell me what you did wrong, I will not punish you. I will just discuss it with you and listen to you and help you get through it. If you do this, you have better than 90% chance that your kid will tell you or talk to you when they have a problem. If they are afraid that they will make you angry, or that they will get grounded, or that they will feel that you're disappointed in them, they're not going to talk to you. Also, give your kid a hug. Tell them you love them. A lot of parents think when their kids start going through their teen years, they don't need that closeness. Not true. They need closeness. They just don't want it as often, and they don't want it in public. I have lots of kids who would come to the clinic and say, I just came today to get a hug because I just need a hug today. And that's sad if they can't get that hug at home. So parents need to remember that. And it's okay if you tell your kids, I love you, and the kid just, looks the other way and move. That's fine, but they heard you. And that's important. Keep doing that. It will protect your kid.
So when you mentioned about talking to kids, one of the questions was, what do you do when your kid won't even listen? You can see that there's an issue, there's a problem, but they won't talk to you about what they're feeling. So there's a wall there. So what do you suggest there?
Right. So the wall is there because either there was never that closeness or trust, or there is a feeling in the kid that the parent doesn't care enough, or that the parent's going to lecture them. So the easiest way to get out of this is don't try to talk to them in a formal way. Hey, sit down, let's talk. What's wrong with you? What's happening? That never works. What I would do is let's do an activity together. Let's go do gardening, or go drive around, or go to the park. And while you're driving, while you're doing that activity, chat. And it's okay if they don't say anything the first time. Do it the second time, the third. When you do it right, and they feel that you're doing it because you care and you want to help, they will talk. This is why I went into adolescent medicine. I was already a gynecologist, a physiologist, a pediatrician, and then when I went to see a teenager, I couldn't get him to say a word to me. And I went and trained with this lady that was 78 years old, that was working 44 years with teens, and tried to learn from her. And over time, I did learn. And now I don't think there is a kid that I cannot talk to or have to. And that's how it is as a parent too, with my own kid when he was a teenager. It's you learn you learn what works and but keep trying. Don't give up. Sometimes the kids, that's exactly what they think. You try one time and you give up, and in their mind, hey, she doesn't really care that much. She just wanted to check that box. So keep trying. Don't stop, and don't do it formally.
Okay, good suggestions. Thank you. Do you have any information on data on a link between underage drinking and suicide attempts or completion? Is it a risk factor because alcohol use is one way youth deal with their depression, anxiety, etc.?
Yeah, self-medication in general is a big problem among young people. Their brain is not developed enough. The effect of these drugs is much worse on them than in adults. There is enough data similar to what I showed about substance abuse. Alcohol also carries about 7-fold increase in suicide attempts and completions. So that's why I keep saying people should start talking at age 6, 7, 8, not 14, 15, when they're among peers rather than among parents. And most importantly, the worst part parents do is tell their kids not to do something that they are doing. If yours, I have so many kids who their parents are yelling at them, screaming for smoking pot, and the dad has a big stash of pot under the bed, or the parents are drinking alcohol every day and telling them kids don't drink alcohol. Or it is very important for the kids to understand, why is it okay for you, not okay for me. I remember a kid I was giving on a youth forum talk to kids about dangers of early sexual activity, and one 13-year-old said, why is it okay for you grown-ups to have sex and not okay for us? And if we're not honest to them to explain to them why, just tell them don't do it, because that's really what we do in the US, right? We keep telling kids don't do it, right? But we never try to explain to them why. And then what happens is they go look it up on the internet or from their peers, and then they get the wrong information, and it's a problem. So talk to your kids and don't ask them not to do things that you are doing every day.
Okay, that's great. Okay, hold on. How do I get the best help for my child? And you mentioned that a little bit. It's a lot, looks like it's a lot of sometimes trial and error, asking other parents.
Yeah, it's very hard. This is the reason adolescent medicine specialty was created in the early 90s because pediatricians are not comfortable with teens and adult doctors are not comfortable with teens. And the same goes for mental health providers. So that specialty was created, but because like everything in our medical healthcare system, very quickly people realized, why should I spend 3 more years in training and adding more loans, and then I get paid less than a general pediatrician or something.
Wow.
So less than 600 people in the country are adolescent medicine specialists because of that. And so really to be an adolescent health specialist, you have to care, you have to want to do it. And like for me, this is the most rewarding thing that I ever done, is when I see a 15-year-old who is at the crossroad between going down the drain and bad behavior or getting better. And when I get an email from a 30-year-old telling me how their life is great now thanks to the time we were here. I mean, I have kids that starts with me at age 7, 8, and they go to college and come back and want to stay with it. That's what is fun about it, but it doesn't pay your bills. So ideally, the best help is through an adolescent medicine specialist. There aren't many of them. There aren't any program. I'm no longer at UK, where I used to never refuse to see any kid, no matter what time, and even if they come last minute or whatever. Now everybody is looking at how do we generate money, and I never thought of it that way, and that's part of why I'm not working there anymore or anywhere else, because for me it's more important to help the community and help the kids. There are a lot of good people out there. They don't have to be adolescent health specialists. They have to be caring enough. And I think a lot of people, like I've been working with Boyle County schools for the last 12 years or so. The people there are amazing, the nurse, the counselors, and working together with them, it was always, I trusted them to do all the good things. I would see the kid one time, tell them what needed, and they would do all the other work. So how to find best help? Talk to your pediatrician. They might know who else is good that works with teens. It doesn't have to be an adolescent health specialist, but anybody who is known to care about the kids. For kids, most of the time, it doesn't take much. I mean, a lot of these kids that call me in the middle of email me in the middle of the night, and they say, I know you're not going to see this email, it's 2 a.m, but I'm just writing it, and knowing that you care about it is already making me feel better. So kids need just someone to really listen to them, show them that they understand their pain, and they will get better with it.
Okay. We're going to go to the last question. I do realize there are more questions out there. Dr. Omar, it's up to you if you feel like you want to continue going, or do we want to just take this as the last and I'll send the rest to you.
Whatever works for you. I'm
Okay.
happy to answer anything.
Okay. I have a student who recently attempted suicide. Coming back to school, should our teachers be told why she was out, or should it remain confidential?
I think the right thing is not to leave it confidential. I mean, it should stay confidential, meaning between you and the teachers. Like, you don't advertise it, but the teachers should know, because the teachers are one of the best protective factors there. If they are aware, they are less likely to, for example, yell at her if she didn't do her homework or something. So the teachers knowing that she's at risk is a big, very important factor. They will be part of the treatment, not part of the negative stuff.
Okay, that's very important. Yes, I can see that. What are your thoughts on using the phrase committed suicide versus completed suicide? I was told the term committed suicide should not be used anymore.
Yeah, I mean, this is ongoing for so many years. We pay more attention to how do we phrase a sentence or something, rather than actually doing something. I'm aware of it. I think completed suicide is a better sentence. I think actually, if it's up to me, I'll say died of suicide rather than committed or anything else, just like listed as a cause of death. But at the same time, I think we should be working harder on helping the kids rather than figuring out which word is better than the other.
Okay. Um, let's see. Would it be a good idea to provide local resources to parents without saying anything if the parents are not supportive?
I would provide resources no matter what. I mean, if it's up to me at the beginning of the school year, I would, the first meeting of the PTO in each school should address issues like, again, talk about, even if they don't like it. And most parents, unfortunately, don't like it. I remember the first time I talked to parents in Kentucky, they yelled at me and were mad, and complained to the principals. But then with time, they learn because they're not used to. We are used to in this country to say just don't do it. It's like one of those common examples is again fighting against teen pregnancy and STDs. So if you look at Sweden, they start talking to their kids and they tell them everything by 5th grade. And here we don't do anything.
Right.
If you look at the percentage of kids having sex in Sweden, it's exactly the same as here. Talking to them about sex did not make them have more sex. The difference, their teen pregnancy is 20-fold less than ours, and the same with STDs, while ours continue to have a problem because we don't want to talk. So I think providing parents with resources about all teen issues, something like what you did in those handouts about suicide, about STDs, about contraception, about depression, about all those things. And it's okay if the parents don't ask for it. At least they would have it. And if something happens, they might remember to look for it.
Okay. It's a tough one. How can we support parents who lost a child to suicide despite being loving, supportive parents, and they were vigilant?
It is I can't even come close to putting myself in their shoes, because losing a kid, period, is a very tough issue. Losing a kid to suicide is always making the parents feel like it's their fault. I have a parent who lost 2 kids to suicide a year
Oh, wow.
apart, and it's beyond devastating, and I think it is important, if you know such a parent, be honest, that keep repeating to them that there are things in life we cannot prevent, and there are things, how do we move forward? Like in this parent that I mentioned who lost the 2 of them, is doing amazing work trying to help other parents not to go through the same thing. And that's usually the best remedy, the best way to do things. Get them engaged in helping teens in other ways. I think that it's never going to compensate for losing your kid, but at
Right.
least you would feel that you're doing something to help another parent not going through the same thing.
Yes. That would be horrific. A student continues to make suicidal statements and has recently been diagnosed with depression. The parent is reluctant to provide the child with medication. How do you approach this situation?
Yeah, this is one of those problems that we keep running into. And my approach has always been, I would sit down with the kid alone and then with the parent alone. And I explained, parents are afraid. They might not be bad parents. They're just parents who heard something from either internet or a neighbor. There are a lot of people who put misinformation. So I generally explain to them what is good and what's bad about medications, that they actually do work, but they don't work alone. They have to be in conjunction with support and family support and counseling support, and explain to them that if done right, there is no risk from them. And then I put it to them, would you rather your kid be dead tomorrow because of no treatment, or having a little side effect that we can handle, even if there is a side effect? And generally, it's like with the vaccines. There are parents who don't believe in vaccines. And I try my best to explain to them. And then at some point I say, okay, If you are not willing and will not agree, here is this form. There is a CDC form that refusal of vaccine. And I say, I want you to sign it, because when your kid dies from this disease tomorrow, don't go sue the hospital or the medical people who advised you and you refused. You will take that responsibility. And guess what? All of them refuse to sign it and say, okay, I want the vaccine. It's the same with medication. I think if we take our time and explain to them, they would agree. The problem is a lot of our healthcare system is such where the pressure on providers, their employer is pushing them to treat 1 million kids a day, and all those things. So generally what happens is you go and they just write you a prescription without explaining to you what is it and what is it going to do and what to expect. I believe that if you explain, parents will come along.
Okay, that's great. Great approach. How do we differentiate between real worries a child might commit suicide and just things that they say in the moment because they are upset and really don't mean it? Things like, I hate my life, nothing ever happens that's good in my life, I just want to die, I'm going to kill myself, I mean it, I can't do anything, and I always fail at everything. Anytime I try to help someone with something, I make it worse.
Yeah, I think there is no such a thing as not serious, for me at least.
Hmm.
Once a kid start getting those thoughts in, even if they were not imminent, the difference is not serious or not. The difference is
Right.
this imminent suicide or not imminent. It
Hmm.
might not be imminent suicide, but the thought process has started. If a kid already starting to think that I'm useless, that I'm failing, that I'm a failure, that I'm disappointment, they are at risk for suicide. I would never say don't take it seriously. Uh,
Okay.
the role of the parent or the teacher or whoever hears the kid say that is to keep working with this kid to improve their self-esteem. There is a problem with the self-esteem in this kid, and unless that self-esteem improves, they're always going to be at risk.
Okay. I have a 14-year-old male who has lost interest, sleeps a lot, and very much an introvert, and having body image issues to the point where he has worked out overly caused some pain. Should I be concerned as a grandparent? No talk of attempted suicide or attempting suicide.
I would be concerned, at least medically, if he's overworking and having body image issues. It will
Hmm.
escalate. These things don't go away by themselves. And if you have an issue with your body image, you're going to end up being anorexic or
Hmm.
something else happening, or self-harm. And anorexia, even though in boys it's 1 to 8 or 1 to 7 boys versus girls, most boys with eating disorder end up dead. So the
Wow.
death rate is much higher than in girls. So I would be concerned, and I would address it and try to get some help before it gets out of hand.
What causes the child to twist her hair and break it off? My child has now lost a huge patch down the middle of his head due to this and won't stop and says, "You can't make me stop. It's my body. I like twisting my hair. What can I really do?"
Yeah, I mean, this is another one of the simpler form of self-harm, but it is a
Okay.
form of self-harm. And same story, you need to get some help, somebody who understands teens, because what is the cause for this pain? That there is some mental anguish that he is relieving by doing this.
Hmm.
It needs a good provider who would get to the bottom of it and understand it. It's probably, if I see this kid, it might take me 2-3 visits with him before I get to the bottom, but it takes time. But he needs help. I would not ignore it.
Okay. Do police officers have training in prevention of suicide? Would there be a better option to go to? It is hard to seek this kind of care with a counselor, etc., due to the wait time. I'm afraid that sometimes suicide people need professional help immediately.
Yeah, ideally, yes. And they do all get some training. The
Hmm.
problem is, like I mentioned during my talk, it's not the correct training. Because, for example, a lot of people in this state have QPR training, which is question, persuade, refer. Refer where? And that's where the weakness of all those things. And I think that what the police officer can do, the parent can do themselves. Do something with your kids. Don't leave them alone. Try to talk to, try to give them something useful to do. What I worry about with the police officer is they're caring people, they want to help, but they're not really trained in adolescent development. They don't quite understand the difference between a 12-year-old and a 17-year-old and a 19-year-old. And the kids, the first thought that comes to the kid's mind when a parent calls a police officer is, they hate me, they don't want me here, they want the police to take me to jail or something. And that's the negative part of it. I'd rather, yes, the wait time is awful. You know, again, I personally, what I tried to do always was have an evening clinic once, twice a week where parents don't have to miss work and kids don't have to miss school. So I can see them in the evening at an appropriate time. And but it is tough. Not every place is like that, and not every person is like that. But there are good people. There are a lot of good people in the state. It's not enough, but I would seek first professional help. Like even if it's not a counselor, you know, a good pediatrician, a good nurse practitioner, a good school counselor. Sometimes a school nurse might end up being better than a doctor who doesn't care.
Okay. You have discussed youth suicide as more of a public health issue than a mental health issue and cite same-day suicides as proof of that it's impulsive. However, I've heard that even attempts that seem impulsive are usually not as impulsive as they seem. Often there's an underlying condition such as depression that the parents were not made aware of. How do you rationalize this?
Yeah, I mean, so the first part of it is you have to understand that teens are not adults. Again, when you are a 14-year-old, if your parent says, "Oh, you got to see you're a failure today," for this 14-year-old, it's the end of the world. In his mind, my mom is never gonna like me. She's never gonna think that I can be successful. And this is part of what. So your kid comes home with a report card, and he has 8 A's and 1 D. And usually the parent starts with a D. You know, why did you do so poorly instead of the other way around? And you know, my advice is if you have 8 D's and 1 A, start with the A, start with the positive, not with the negative. So there is a school of thought that says even those same day suicide must have been something else. I don't see it that way when I interview these kids after the fact. And I don't see that they have suicide. And once they got the support, most of the kids I've worked with, 10,000 kids, like I said, at least suicidal kids in the last 20 years. And many of them, if that event, that same day event, same day crisis was handled the right way, they didn't have problem before, they don't have problem after. And, you know, the CDC took 20 years to investigate this and look at all the data in the world. And for them to finally come out and say, yes, we agree 54% of all suicides are not related, or the mental health part is not the main part in it, in the same with the World Health Organization, I think it's validated this. And if we continue to look at it as mental health, it will just continue to increase. You know, unlike our healthcare system, the healthcare system in New Zealand is free for everyone, available, whatever. And back in 1992, when the government there realized that suicide is a big problem, they did the same thing. They asked for help, and the mental health specialist told them it's a mental health problem, so we should use the treatment model, and this is how we prevent suicide. Well, 1992, the rate was 13. Now the rate is 17.9. And that's a government who is spending a lot of money on suicide prevention, unlike us here. You know, they are trying, but that's never going to make a dent because it's the wrong diagnosis. So that's my, at least again, in everything that I looked at, every data that I looked at, every study that I looked at, I'm more convinced than ever that a lot of them don't relate to mental health. And again, the fact that when you add more mental health intervention, you have worse outcome. That tells you something. It's not that psychiatrists who are treating are bad. It's nothing changed in the household. Nothing changed in the conditions that led to suicide. If it was just, say, a mental health problem and you treated it, they should be better. But they don't get better. Their suicide rate increases 300-fold because nothing improved in the
Every
condition.
place else, whatever was pushing it. Okay. Are you currently taking patients, Dr. Omar, or you're out of practice right
No,
now?
I'm out of practice, unfortunately, and at least
Okay.
for now, and I'll be moving probably to another state.
Okay. Just a lot of people saying thank you. This was excellent. Let's see. I think we've hit the last, and I apologize, everybody. If I missed a question, I promise you I will send it to Dr. Omar tomorrow. Michelle, I'm just going to bring you in. If you have anything you would like to say, I just sent you the webcam request. I think we covered pretty much everything. Dr. Omar, I cannot thank you enough for the presentation and just answering these questions, because it's scary if you're dealing with that and it's your child or somebody, you know how scary it can be. And so I just appreciate everything that you've done and staying on as long as you have. Michelle, is there anything else?
Just a couple of quick things. One person complimented Dr. Omar, your passion and insight and life work on this horrible disease. We can't thank you enough for your time sharing this presentation and also your extra time this afternoon. Thank you so much for that. Mary Beth, you as well. We got compliments for the collection of information that we were able to put together and the approach that we took with the tough topic. Just a nuts and bolts kind of thing. We did have someone seeking more information on self-harm and cutting. And I did want to let the group know we still have over 400 people on live with us, that we do have a webinar in our library posted on self-harm. And so please feel free to refer back to that. And if anyone, and we'll also ask Dr. Omar after the presentation on experts in that area, folks are asking for more in the area of self-harm and cutting as well. And then we also have someone that's very interested in knowing, so I'm just throwing this out to our entire group. If anyone has studies or research or data showing that art has helped teens, specifically suicidal teens, deal with depression. So I don't know if you could point us in any direction there, Dr. Omar, or if anybody else wants to email us after the fact, that would be great.
So there is some studies, I can't now bring them on the top of my head, but we just published a book, actually says, titled Suicide, The Broader View by Cambridge Press, that had a really nice chapter on the role of art in treatment.
Oh.
So there is enough data about art therapy, horse therapy, pet therapy, any of those things. Kids care a lot. They you might not notice it, but they're very caring. I mean, I prefer to deal with teens than any adult ever. If I ever have a choice, I'll prefer to work with a teen than an adult. People think I'm crazy, but they are more fun, they're more real, they're more honest. I keep repeating, teens never lie to me. They give me, if I ask the right question, I'll get the right answer. And if generally what happens is you ask them the wrong question and you get the wrong answer and you think they are lying. So they care. And things like art and music in pets, all those kinds of therapies are very, very useful. Things like mindfulness, even yoga, things like that.
Mhm.
One of the best things I personally do with kids is give them something to do. You know, I have suicidal kids who are doing better. I have her or him work with a new suicidal kid. I have an anorexic who is recovering. I have her work with another anorexic. This make them so happy. They make them feel useful. If you give your kids a chance to feel useful, they will do fine. And I'll share with you a very old saying by an Arab poet from 5,000 years ago, who said basically, if you are young, if you are rich, and if you have free time, then you are in trouble.
Mhm.
And that's exactly what we should remember is if we don't give our kids something useful to do, they will end up doing something that is not useful. And,
Yeah.
and that in part also accounts for how things were 50 years ago when the kids on the farm helped their parents and worked with them. And now, you know, like one kid, I always remember a 16-year-old who attempted suicide on his birthday after his dad gave him a Corvette for his birthday, for his 16th birthday.
Wow.
And the dad was a surgeon, the mom was a psychiatrist. And the kid told me after that, you know, yeah, Corvette is nice, but I'd rather have a dad.
Mm.
Meaning that, you know, it would have been nicer if he actually spent 5 minutes with me rather than just, you know, giving me things.
Right.
You know, another saying is, if you want the teens to do well, stop giving them things.
Yeah.
And that's really important. It's not about material things. It's about make them feel that they are part of your life. Make them feel that they're useful to others. That's when they do well.
It's a good things to leave it with. Yeah, it's very good. Again, thank you. And just a reminder, everyone, tomorrow around 3:30, 4 o'clock in the afternoon Eastern time, because we're Eastern time, you will receive a follow-up email, and that will contain the webinar recording link, the survey, this is going to be a survey that'll pop up on your screen when we end today. And also, it'll be there in your follow-up email in case you didn't get to it. You can fill it out then. As well as for those attending live, a certificate of attendance and link and information about the handbook. So with that, I'm going to say thank you again and goodbye, everybody. And thank you for sticking with us through this, but it was such a great conversation and topic. Dr. Omar,
Thank you, ladies.
Nice work, Dr. Omar. Have a good evening.
Thank
You too.
You
Bye.
too.